to go ahead with it. We were lucky. I was lucky to meet my
Good
own
evening,
colleague.
madams.
Good evening, ma'am. Good evening, ma'am. Good evening, Parvati, ma'am. Welcome, ma'am. Parvati, ma'am is one of our senior consultants who's there with us. She's a very senior teacher to all of us. Good evening, ma'am, for joining us. So we're very happy. All we have a lot of young and old people who have been very senior faculty who has been joining us from across the country. I'm sure once the live streaming goes, we'll be able to reach many more. So we were quite lucky to have a very good speaker who's my batchmate and a good friend who happened to meet last week, and this is something which she floated across, and we're happy that she took it up, even though she's not at her best and she got the flu recently. We are sure we're going to have an excellent session today. Preeti ma'am is the right person to moderate. She is been championing the cause, and I'm sure she is one of the few who will have an actual experience in dealing with such children, while many of us among pediatricians are quite gray regarding when it comes to psychosis and in general adolescent health as such. Over to you, Preeti ma'am.
Thank you so much, Jijo. This is a wonderful session which Jijo has organized, taking the lead. Thank you, IAP Kerala, for taking this on. It's a pleasure to introduce Dr. Meha Saxena, MD. She's a board-certified adult, child, and adolescent psychiatrist with leadership experience in academic medicine, clinical program development, and medical education. She is a clinical assistant professor and assistant program director of Child and Adolescent Psychiatry Fellowship at University of Connecticut Medical Center with expertise in mood and anxiety, ADHD, neurodevelopmental disorders, trauma-informed care, early psychosis intervention, and culturally responsive psychiatric practice. I love this. Culturally responsive psychiatric practice. She's recognized for excellence in teaching and a strong commitment to mental health, equity, and mentorship of fellows, residents, and medical students. She has received a number of honors and awards, to name a few: Excellent Educator Award, Best Teaching Award. She has published widely and she has spoken in many conferences. So we are honored and privileged to have you with us, Meha. So it's over to you to speak about early onset psychosis, which is less spoken about and probably less seen in clinical practice, or are we really missing it? We will come to know more by the end of your talk. I request everyone to listen in carefully, keep your questions ready, and Meha would be sharing her thoughts with us, and then we will take her head on. Over to you, Meha.
Thank you so much, Preeti ma'am, and thank you, Jijo. This is really a pleasure and an honor for me to be here today and speaking about this. This is truly a passion topic of mine, and I had never imagined. I was actually just traveling to India for a college reunion, and as luck would have it, I met Jijo and we got talking. And our batchmates are joking that only good thing that came out of the reunion was this collaboration, and that I'm here today talking about this. So I'm really thankful to you and really thankful to this organizers of the International Adolescent Health Week to give me this opportunity. Without further ado and wasting time, I'm just going to share my screen. So let's see. We'll go back to this. Are you able to see my screen?
Yes. Yes.
Okay.
Yeah.
Okay, perfect. So I'm going to talk about understanding early psychosis in youth. This is actually something, as I said, it's like my personal passion project. And I started early psychosis like at the hospital I'm working at. We used to get a lot of patients and a lot of referrals from pediatricians and schools and also just counselors. But there was no specialty. So when I joined the hospital, I wanted to study specifically for early psychosis in youth. And I founded this clinic and I'm the director of the clinic. So I see actually a lot of these cases. So let me start with, 1 second. Okay, so let me start with why is this important? And as pediatricians, I think you all are It's similar in US and in India, full speciality, which kids and kind of like the gatekeepers, the best advocates that these kids have. And they are the ones who would be able to see the early signs of psychosis in youth. And psychosis, I mean, although most of it is diagnosed in adulthood, but it can emerge during late childhood and adolescence. And there is a 3% lifetime prevalence. Why is early detection important? Early detection is really important because it reduces chronic disabilities for these kids, and it preserves critical developmental trajectories and reduce the risk of self-harm, suicide, harm to others. I can't even tell you how many kids I see in the psychosis clinic, which are all adolescents, and they come up with a multi-array of symptoms. Like the symptoms would be from anywhere to anywhere. They would be suicidal, they would be homicidal, they would be hearing voices. And again, what do we do about it, and how do we filter them out? How do we follow them up? So I think this is important to kind of just understand a little bit about how their onset could be before 18 in up to 18% of cases throughout for psychosis and schizophrenia. The other important thing which I really want to highlight today is that there is a lot of these kids or youth or adolescents that report psychotic-like symptoms, but most of them do not develop psychotic disorders, but they remain at risk for other psychiatric disorders, which is where the gray zone is. And it's really not like black and white. It's not like, oh, this kid is psychotic, this kid is not psychotic. It's really not that. And that's why it's like really important to kind of have these conversations about what do you do when a kid is reporting these symptoms? Where do you intervene? How do you treat them? So childhood onset, we call it childhood onset psychosis if it's less than 13 years. Adolescent onset is 13 to 18, and obviously adulthood onset is above 18. The male-female ratio is, for younger age group, it's 2 to 1, and for adolescents, like around 1.5 to 1, and adult is 1.2 to 1. Which is the other thing which is important is the early onset schizophrenia, which is before 18. It affects approximately 0.5% of children and adolescents. Now, this number might seem smaller. We think about like, what is 0.5%, right? Like we are seeing like 100 patients, 200 patients, like what is 0.5%? But the point is that's the number for early onset schizophrenia. It's not the number for how many kids are presenting with just psychotic symptoms. And there is a difference between that. And as I said, not every kid who's presenting with psychotic symptoms is schizophrenic. And that's where it is really important. So before working at the outpatient setting, I used to work at an inpatient setting, and I used to see kids who were admitted with hearing voices, seeing things. These kids are started on antipsychotic medications, but I would tell you that 75% of them were not really psychotic. Like they were having psychotic symptoms, but they were not having a psychotic disorder, if that makes sense. Like there's a big difference between those two. And I'll talk more about it in my presentation. So let's go on with like very early onset schizophrenia, which is extremely rare, which will be before age 13. So if you're actually, somebody is telling you that a kid schizophrenic before age 13, think about it, that it is possible that it's not schizophrenia, because the incidence is like really rare. Like it's very rare. So it could be a misdiagnosis mostly, or it could be something that somewhere is missed by someone or a specialty, or something is going on there. But it's very rare, just to say that. And it's actually consistent. This epidemiological pattern is consistent across countries, not in just US, India. It's where that's kind of so. Let me start off with this. This is actually that I saw in my clinic. It's a 15-year-old boy living with parents, presenting with symptoms of isolating himself, doing poor academically, poor grooming and hygiene. Thinking that everyone's watching him all the time, and reporting of himself. Was really good academically until like ninth grade, but then that who had been reporting that he doesn't talk much or interact with other kids, stays with himself. There's some anxiety, mother, depression, father, no prior psychiatric hospitalization or outpatient history, some counseling history, but no previous trials of medications. So these are the kind of cases that I see in my clinic. And so I kind of wanted to go over, like, what would you think is going on with this child, right? Like, this is again, just going back, like 15-year-old with presenting with these kind of symptoms. So it could be a psychotic spectrum disorder, of course, like, it's coming to a psychosis clinic and coming with psychotic symptoms. It could be a psychotic spectrum disorder. A major depressive disorder could present with psychotic features that is high on differential. Or on all these cases, major depressive disorder is very high on differential. Anxiety disorders are so common, they're so prevalent. They're present way more than a kid with schizophrenia or psychosis. So it could be a manifestation of anxiety. It could be trauma. Kids with trauma while growing up, like any kind of trauma, their parents separating, some physical abuse, or kids with sexual abuse. Any kind of trauma could lead to this. Underlying medical or neurological conditions could cause that. And I mean, you guys are actually the expert in differentiating these medical neurological conditions. But it could be this kid was having some medical neurological condition and which is not being diagnosed, and he's presenting these. So this is just kind of brainstorming what all you can think about. So how do you proceed if kids on your practice and some psychotic like all new. So one of the main things is history. History is such key to these cases. A thorough medical history.
Meha, excuse me.
Sorry.
I would request you to shut down the video. There seems to be some network issue. Your voice is breaking in between. So would you try it continuous from the flow which you are at this point? There's some audio disturbance in between. So can you just try it without your video on? Possibly this happens when there's some internet disturbance. Yes. Shut your video and continue without.
Okay.
Yes.
Okay, sure. Yeah, I got it. Okay. Let me know if this is better. Okay.
Sure.
So thorough medical history and psychiatric history, especially the chronology and progression of symptoms. Why is this important, the chronological, the history part? Because the thing is that, a lot of times when these kids come to us, it's already been like 6 months, 8 months, or maybe more time has passed before they have come to you. So we really need to know, like, how long this has been going on. It's very important to separate the parent and the patient for interviews, because a lot of times kids do not feel comfortable talking in front of their parents about what exactly is going on, how they're feeling, especially substance use. No teenagers are going to accept in front of their parents if they've used a substance. I mean, I have so many kids who use marijuana almost consistently. They would never tell their parents that they're using marijuana. So these kind of sensitive things, you have to ask the patient themselves. Any substance use, any how long the symptoms been going on, how severe is the symptoms, any recent psychological stressors that they're facing, what is the trajectory of academic decline, what is the trajectory of social functioning, are they isolating themselves, are they not hanging out with their friends. Then ordering a medical panel, of course, to rule out any kind of any kind of like underlying medical causes like thyroid, CBC, comprehensive metabolic panel, neurological conditions that you could think of. I generally order hemoglobin A1C just so that if we are considering meds down the line, like antipsychotics specifically, so that we have that number so we can make that decision. So kind of ordering a full medical panel and taking a thorough history would be the first steps to start with. Sorry, my slide is stuck. 1 second. Okay, so points to consider. Again, developmental history is very important. Why I say so? Because a lot of times these kids have something like delayed development, or something that you find out that they are autistic, they have learning disorder. And what happens is eventually they have really poor coping skills. They have poor coping skills to social stressors. They don't know how to express themselves. And these voices, they say that, oh, I'm hearing voices. These are actually manifestations of how stressed they are, and they're not able to express themselves properly. So a developmental history is really important in these kind of cases to really figure out where this kid is developmentally. Sometimes with low IQ kids do not know how to express themselves in social settings. They might be saying they're hearing voices, but they're not. These are just their own voices that they're hearing in their head. Or it is important to kind of rule out what is true psychosis versus not. Early childhood history is important. Any kind of trauma history is important. We have to remember there is a factor of shame involved for both parents and the patient, especially when it comes to psychosis, because psychosis is not something that people are proud of. I mean, if you think of anything, there is such a stigma related to being called crazy. It's like, oh, you're hearing voices, you're probably crazy, and other kids are going to call him crazy. Other parents are going to say, oh, these are the parents of a crazy kid. So there's such a shame involved. So we really need to like tease out what's going on with them, and are they open to intervention? Are they open to treatment? And psychoeducation is also really a key point here, is because we want to tell them that because you're hearing voices, you're not crazy. It doesn't mean that your kid is going to be labeled as psychotic for the rest of their life. Like, there's treatment options, there's all these interventions that we can try. So that's why I'm saying, like, these are some things that are anti like this. So timeline of symptoms, we discussed that, it's very important. Have they tried any non-medical interventions? Again, sometimes when these kids come to you, they've already tried like something that someone has suggested, some non-medical stuff, some non-pharmacological things, some over the counter, like some stuff they have tried already. So it's important to kind of understand that there a counselor involved. What's the relationship dynamics between the family? If we can get collaboration from school, that would be very helpful, because the thing with adolescence, it's such an interesting period. The kids spend half their time at home and a lot of time with their friends. So parents can report, but school might have a totally different report of symptoms, and they might say, yeah, the kid is like this at school, like that at school. So collaboration in school is very important. After sending referral, it's important to collaborate with psychiatrists and therapists and follow the term to kind of see where we are heading with that, because a lot of times psychiatrists would see the kid and then they will be lost to follow up. They would just stop going to the psychiatrist, and they would stop taking the medication. They would stop going to the psychiatrist because again, stigma. There's like, who wants to go to a psychiatrist? Who wants to see a doctor who sees crazy people? So then what happens with these kids are they decline. And for as pediatricians, I think it's very important to continue following up these cases and making sure that they're following up with the treatment. They're still in treatment. They're not like lost to follow up. And that's what is like one of the important things. So I'm going to talk a little bit further about prodromal symptoms and all of that, but I just kind of wanted to say that some things to keep in mind is when we're taking history of these kids, if we can kind of note down whatever the parents are suggesting, when did the social withdrawal started, when did the communication changed, when poor self-care or academic decline, abnormal sleep patterns. I put down COVID-19 pandemic because this is very, very, very interesting. I've been doing this psychosis clinic before the pandemic and during the pandemic. I have to say that the number of referrals to the psychosis clinic has increased like tenfold since the COVID-19 pandemic. What happened with the COVID-19 pandemic is that isolation was normalized. The functional deterioration some of these kids were having, it was just masked by not going to school, and nobody is reporting anything. Nobody is checking on these, sitting in front of the screens and doing some online classes, playing video games. Like, we missed a lot of these kids during that time. And there was the isolation part, which was just a part of routine pandemic, and then we don't know if these kids are actually having social withdrawal, or is it just like a societal withdrawal that we all were having. So the COVID-19 pandemic, and actually there's studies that have shown that since COVID-19 pandemic, the rates of psychosis and the cases of psychosis have immensely increased. For whatever reason, it was increased stress during that critical neurodevelopmental period. There was a lot of things which. So cultural factor is such an important thing. I can't stress enough about this whole cultural factor thing. So I'll tell you a small story of what happened, which is actually important of cultural factors. So my cousin, she lives in the US and her kids goes to school in the US. They were visiting India, and my nephew, who's 6 years old, went back to the US and told his classmates that while they were visiting India, there were monkeys which came to the house, opened the fridge, and ate something from the fridge, and went away. And he's telling these stories to these kids in his class, and these kids went to the teacher and told the teacher that he's sharing these stories. The teacher reached out to my cousin and said, I think your kid is having psychotic symptoms, that monkeys don't go to the fridge and open and eat something from the fridge. And my cousin was like, no, they do. They do in India. They come to your house and they can open the fridge and they can eat. And the teacher was shocked, and teacher was like, what are you talking about? Like, that doesn't happen. Like, this kid is psychotic and he's delusional. And my cousin called me and she's like, what do I tell this teacher? Like, she's American, she doesn't know anything about like Indian culture. So the point is, cultural factors are so important. We might think something could be so psychotic or so out of context for us, but it could be culturally acceptable for that particular culture. So it's very important because we see sometimes these rural patient population, and they follow certain practices, they do certain things. It's very important to understand, is it normal? Is it normal in their culture? Like, just asking. I'm sorry.
Do continue.
അത് ഡബയിലിട്ട് വെക്കാം. കുറച്ചിന്ന് കഴിക്കും, കുറച്ച് ഡബയിലിട്ട് വെച്ചാൽ
One second. Let me just mute the participants. I
ഡബയിലിട്ട്
request all the participants to keep kindly mute yourself.
ഇത് രണ്ടും മതി. നാളെ പിന്നെ നാളെ മുറിക്കാം. അതെ.
Okay. Continuing with the red flags, I put the slide so that you all could like kind of have some idea about what are some of the things to note, or seeing these things that a kid present you are check, and his academics have been dropping, he's been isolating, or there's reduced motivation, and then the kid is reporting some auditory visual hallucinations, some sensory distortions, which means they're saying, oh, I see a bug crawling on my skin, I can feel like something on my skin, some sort of sensory distortion. There's attention difficulties, there's memory difficulties, there's some suspiciousness, magical thinking. An example would be like the kid is saying, oh, I can make a car, I can make or go into an accident, or I can crash a car, I can talk to my plants, I can see the aliens coming to the earth. So these kind of like really magical ideas, delusional ideas, like delusion ideas are false belief sets. They would say, oh, I think I'm the king of the world, I'm the Superman, I can make anything happen. Again, very important to understand what is developmentally normal and what is psychotic, because some kids developmentally, they would say such things. They would say, oh, I'm a Superman, oh, I'm this, I'm that. That by itself is not psychotic. When you think of psychosis, think of it in a broad range of symptoms, broad way of things, that not a symptom alone, but the entire presentation. What else is going on with this kid? Where else is this kid lacking? What else is the parents reporting? What else is happening in this kid's life that could say, okay, yeah, this kid is really falling in the psychotic spectrum? So just keep that in mind. Think about these things as red flags. I didn't want to go into details of this because I'm pretty sure this like DSM criteria, everything is available online. You can like look it up, but just just very, very briefly, the brief psychotic disorder is presence of psychotic symptoms for less than 1 month. Anything between 1 month and 6 months, it's called schizophreniform disorder, and schizophrenia is over 6 months. So just kind of like timeline wise things, but otherwise, to be honest with you, I for me, like this terminologies mean nothing. Like if a kid is having psychotic symptoms, what is more important is to like follow their trajectory, like what is going on with them, where are they. These diagnoses mean nothing because these timelines are not never accurate anyways, because if the kid is even telling you 1 month, who knows, it might be 3 months, 4 months, 5 months, like we don't know that. So what is really important is that psychosis happens in like different phases. There is a prodrome, there's a prodromal phase, there is acute phase, there is a recovery phase. Prodrome phase is called mental state. So prodrome is basically this period of deteriorating function where the kid is starting to isolate, where the kid is reporting, as I was saying, some kind of symptoms like hallucinations or delusions or unusual behaviors, unusual thinking, some anxiety, some academic problems, deteriorating self-care skills. The prodrome can last for weeks to months. Sometimes the prodrome can last for normal for a long period of time. This is why it's very important. If we start noticing this and there is family history of schizophrenia, we should be really monitoring them closely. We should having them come in more regularly, more frequent checkups, like what's going on. So it should just raise concerns that why is this kid having these bizarre some symptoms. So that's why recognizing prodrome is important, and it can last from anywhere from weeks to months at a time. The acute phase is when there is actual symptoms. There's actual hallucinations. They're reporting hearing voices. They're reporting seeing things. They're doing some psychotic behaviors. They're running naked. They're, they're thinking that aliens are here. They're paranoid, something like that. And it comes with real functional deterioration. An acutely psychotic kid will not be able to function in the school, function at home. Like you would be able to tell that this kid is psychotic. Recovery phase is what comes after acute phase, with or without treatment, mostly with treatment, of course, the recovery phase. But sometimes the psychosis can remit on its own, and the kid could go into recovery phase on their own without any treatment, and they can remit. There could be some ongoing symptoms, but for the most part, most of symptoms can remit. There is residual phase. What recovery is, this kid does not go back like 100% baseline. Like the kid would still have some residual symptoms, and these symptoms could be negative symptoms or positive symptoms. Negative symptoms such as social withdrawal, lack of motivation, just lack of showing emotions, or flat affect. So these things can persist even after the recovery. Chronic impairment. Some of the patients can remain chronically impaired by persistent symptoms that have not responded adequately to treatment. So we kind of have to think about it. Is this the schizophrenia or the psychosis is not like just from one end to another end. It goes through these phases, and the kid can switch between phases at any time. It's not like clear. It's not like 1 is going to happen, 2 is going to happen, 3 is going. No, it's not. A kid could be prodromal, and it could just do recovery and never have psychosis in between. But then the next cycle, they will start with psychotic symptoms, and then they will have chronic impairment. So these are just phases. These are not stages, but phases that a kid could have with psychosis. So to be honest with you, so there are some standardized scales that the psychologists generally use to diagnose psychosis or schizophrenia. They're called KSADS, Kitty Schedule for Affective Disorder Schizophrenia, PANS, Positive Negative Syndrome Scale, Brief Psychiatric Rating Scale. But as I said, to be honest, the psychosis is a clinical diagnosis. I've always diagnosed a kid with psychosis or schizophrenia clinically. These scales are something that the psychologists generally use, which is fine. I mean, they have a lot of symptoms. There's a checklist, and there's like rating scales, which is great. But what you see clinically can never be equal to doing these scales. These scales, people can lie, people can say things, they're not reliable. I mean, how reliable is a 14-year-old kid? Like, how are they reliable actually? So what you see clinically is the most important thing. And that's why we really need to pay attention to what the history is and what they're reporting, what's going on with them functionally. So clinical things that are very helpful. So some practical tips I thought would be helpful. If somebody, suppose you're in practice and a teenager comes and they're reporting that they're hearing voices or they're seeing things, what would be important to understand? What kind of questions can you ask them? You can ask them, is it one voice? Is it multiple voice? Is it a command type voice? Is it only happening when you're sad, or is it happening throughout the day? Does it come and go? How often does it come and go? Does it get worse when you're stressed? Does it get better when you're not stressed? Is there like a stress involved? Are you grieving something? Is it related to sleep? Did you have fever when you have these hallucinations? The duration of it, frequency. Does the child think that this is bizarre, this is unusual, or do they think this is normal? To differentiate between mood disorder voices and psychotic voices, mood disorder voices, kids actually know that something is wrong. They actually think that, yeah, this is not good. I don't like it. I don't appreciate it. Those are the kind of kids. They think this is normal. They don't find anything wrong with it. They're like, yeah, this is fine. I'm okay. This is okay. The insight, which is like their own questioning the experience or not, is very poor in psychotic kids. So that could be a huge factor to differentiate. Then we want to understand, as I said before, school. How are they doing in school? How are they doing socially? Are there co-occurring symptoms like depression, anxieties, their history of trauma? Is there substance use? Is there mood swings? Again, I think I've said it enough times, but early intervention really helps these kids. That is the only thing which actually helps these kids, because it reduces the duration of untreated psychosis, and less time the kid is not psychotic, the more they would have returned to baseline, and the more they would do better in their future life, career, social functioning, everything. Appropriate referrals of obviously or psychiatrist or whoever is in the area who is specialized in seeing these kids would be the best thing to do. But there are certain times when you are in rural setting, or you are in a place where there is none of this available. Then being familiar with antipsychotic medications and antipsychotic medication titration or monitoring, that's completely doable, and it's super easy. And there is really for how to monitor kids on antipsychotic medications, and I'm going to share it in a little bit. But again, as I said, family psychoeducation and psychotherapy is so important. It's one of the most important things. The thing is that these kids and these parents, once they hear the word psychosis, they're like, oh my God, like what happened? Now my kid is psychotic. It's never going to get better. So educating them, advocating for the treatment, advocating for the kid is extremely important. Collaboration with school is really important. I keep saying this because the kid spends half of their time.
I do.
So it's those are the kind of things which would really help with further monitoring this. Some of the poor prognostic factors are early age of onset. It's actually really bad if the kid gets diagnosed before age 10 or before age 13. Earlier diagnosis, the more disability of the kid. So that's kind of like a poor prognostic factor. Low family support, absence of precipitating factors, and then just kind of came out of nowhere. Presence of long prodromal phase. This is not considered good, and like has a poor prognosis. Insidious onset, which is these symptoms are lingering around for many months, many years before the first break psychosis. That's a poor prognostic factor. Low IQ, as I was saying, the language issue, low IQ. These kids do not know how to report how they're feeling. They don't know how to understand what's going on. So that's a poor prognostic factor. Multiple relapses, mostly negative symptoms like withdrawal or lack of motivation or lack of language. All of those negative symptoms are poor prognostic factors. Family history is definitely a poor prognostic factor. I wanted to look at this two-hit hypothesis biopsychosocial model, which really, in most research studies, it actually explains why does someone get schizophrenia, why does someone get a psychotic disorder. So it's what has really helped us understand that and explain. Again, this is such a huge topic, and we still don't know the answers. We still don't know a lot of things that has been going on for somebody to actually develop schizophrenia. But this kind of explains at least some part of it. That there is, if there is genetic predisposition, the first hit is right there. That is the first hit. The genetic predisposition, genetic factors, it kind of loads the gun. It makes the individual more susceptible. Then there is a second hit somewhere in adolescence. It could be puberty itself could be a second hit, or something happened during adolescence that could be a second hit, like a social stressor, like isolation, drug use, something else going on in the family, bullying at school, anything which is very, very, very stressful could be a second hit, and the kid could develop a psychosis spectrum of disorder, or just some psychotic symptoms. So this two-hit hypothesis, which explains that how biological is the first hit and psychological and social is the second hit, which really ends up happening is what really ends up happening is the kid eventually develops the psychotic disorder. I kind of wanted to just touch base on, I mean, I'm pretty sure you all are very familiar with the antipsychotic medications, like the first generation and second generation. In US, we generally use the second generation psychotic medication because they're a little more cleaner, less side effects. And they're like, we have some monitoring protocols for them. And that's why we generally use Risperidone, Seroquel, which is quetiapine. Sorry, Seroquel is an American brand name, but quetiapine, Risperidone, aripiprazole, and Zolpidem and ziprasidone. Those are the antipsychotics that we use for these kids. What is really important is the monitoring of these. I mean, start the drug at dose, monitor and titrate. You could like keep seeing them every 2 weeks or every 3 weeks. Like you, for example, you would, if you see a kid with psychosis, first time psychosis, and with psychotic symptoms, you might want to start like aripiprazole, 2.5 milligram for them. And you can start 2.5 milligram, then see them back in 2 weeks and see how they're doing, any changes, any side effects, any any remission of symptoms. If nothing, you can go up to 5 milligrams and then see them back in 1 month and see how they're doing. So you can like easily titrate the doses, starting with this really small dose and go up. What is important for these medications is the monitoring of the labs, which is where it gets a little bit like, okay, if you are going to start a kid on these antipsychotic meds, just make sure you are just monitoring these things because the side effects. So prolactin, elevated prolactin is a very common side effect, especially with Risperidone. It is very, very common. I actually have a lot of kids who have elevated prolactin. So you want to measure prolactin before starting medication, then at 3 months, 6 months, and 12 months. One thing I wanted to say is just increased prolactin does not mean you have to stop the drug or you have to change the medication. It just means that it's asymptomatic hyperprolactinemia, which is without the gynecomastia. The asymptomatic hyperprolactinemia, you just kind of continue to monitor and you continue to get on the same drug, because if it's working for them, you don't want to take away that medication from them. Fasting metabolic, the metabolic parameters like fasting glucose, fasting lipid panel, hemoglobin A1C at baseline 3 months, and then biannually. This is for adults, though. I'm gonna tell you about kids in 1 second. But remember EKG, the ECG at baseline and annually and every 3 to 6 months for patients on ziprasidone and iloperidone because of the because they have the QT prolongation, and we want to make sure that their ECG is not getting messed up with these medications. We want to do liver function tests at baseline 3 months, and then biannually, CBC at 1 month, and then 6 months. And then clozapine is completely a different that's a different set of guidelines, and it's all available. How do you monitor a kid on clozapine? But as I said, like clozapine should not be the first medication to start on these kids, because clozapine is a drug. It causes so many side effects, so agranulocytosis, all of that. So I reserve clozapine for very, very psychotics, and it's not working, or this not start clozapine as the first line by any means. Start any of those: risperidone, quetiapine, aripiprazole. Aripiprazole is great, actually. It really has very minimal side effects, and that's kind of my go-to for these kids. So what else is, so for this thing, as I said, the ACAP, the American Association of Child and Adolescent Psychiatry, they say that for kids and adolescents, we want to monitor the metabolic panel more frequently. Like, you want to do baseline 1 month, 3 months, and then quarterly. You want you each visit with intervention for 5% increase in BMI. Extrapyramidal symptoms with standardized scale like the AIM scale at each visit for 6 months, and then quarterly. All of this is like, remember it by heart. I mean, trust me, I work in the psychosis clinic. I still look at the chart, and I still every time a kid comes, I'm not like, I'm not 100% like knowing that, oh, this is what I need to. I just still look at the chart and I say, okay, 3 months, 6 months, 1 year, what do we need? So these are checklists which are all available on internet. You can totally look at. But once you just know that you're starting kid on antipsychotic, there are some monitoring parameters that you have to follow, and then you want to follow, because otherwise these kids could develop like really bad side effects. So I want to talk about a few cases, because I thought that that would be actually really important. The cases, because these are kind of the cases which you might see, or something similar that you see. I thought that we should talk about some of the scenarios that could present, and how you think about it. It should be like, a kid comes and we are saying, oh no, let's just in the psychiatrist. I mean, sure, they will. You might be in a situation where psychiatrists not available for whatever reason, their appointment's not available, or they're not there in the near vicinity or something. So suppose a 15-year-old boy is brought by his parents after 4 months of academic decline, increasing social isolation, no longer interacting with friends, often appears preoccupied, laughs or mutters to himself. Over the last month, he has been reported hearing multiple unfamiliar voices, commenting on his actions, warning him that teachers can read his mind. He has stopped bathing and insists that his parents have been replaced by imposters. So what I really want you all to think about is, like, look at the trajectory of this kid. There is 4 months of academic decline. There is social isolation, no longer interacting with friends. Then he's also reporting the voices. The teachers, he's thinking there's paranoia regarding teachers. Teachers can read his mind. The activity of daily living is affected. Like, he stopped bathing, and he's thinking that his parents are even imposters. So this is not a depressed or anxious child. This is a psychotic child. Like, this is where you should think about red flags, and you should think about, as early as possible, sending to a psychiatrist, or starting an intervention. Even a small dose, like, even if you want to send them to a psychiatrist, you can still start a small dose and then send them to a psychiatrist. So this is a psychotic. This is a clear-cut picture of a psychotic disorder kid. Now think about this case. 16-year-old girl presents with 3 weeks of severe low mood, poor appetite, insomnia, feelings of guilt that she's responsible. Mother is sick, and she's thinking she's responsible for mother's illness. She's hearing her deceased grandmother's voice telling her that she must pay for her sins. No other bizarre behaviors, nothing else. All of this is in context with the sad mood, the guilt, the feelings of, that responsibility, that, oh, I'm responsible for my mother's illness. I must have done something. The shame associated with it, all of this. And her mental status exam, just so low mood, sad, affect, some self-harm thoughts. But this kid is not really functionally declining like the first one. So this is not truly. I mean, she is hearing voices, but it doesn't. Again, as I said in the beginning, voices is not equal to psychosis. There is other mood disorders that can explain this. So this could be a major depressive disorder and with some psychotic features, or it could be a major depressive disorder plus an anxiety disorder with some psychotic symptoms. So this is not a true psychosis. Then this another case. A 17-year-old male presents after several days without sleep, displaying pressured speech, self-esteem, excessive goal-directed behavior, which means that he's getting up at night and cleaning the whole house, and he keeps cleaning, and he's just not stopped from doing certain things. He thinks he has divine powers. He can hear angels. There is no evidence of any of these outside of these few days of these episodes, which are cycling after days or weeks. So what would you think about it? This is the kid is having this and then becoming okay and has again and then becoming okay. This sounds like a manic episode. Sounds like a bipolar disorder kid with having some manic symptoms with some psychosis mixed with mania. But this is still not psychotic disorder. This is still not schizophrenia. This is we're going to think more about bipolar, and we're going to think about mood stabilizers or stuff like that. So I just wanted to kind of present like a few different scenarios which would just open your mind a little bit to think where is these symptoms coming from and what is the rest of the presentation of the child which is aligning with psychosis, or is it aligning with something else other than psychosis. I mean, they still need treatment, they still need intervention, but at least we'll be able to know what do we do. Do we start treatment for depression? Do we start a treatment for psychosis? You might still refer them to a psychiatrist. They might go or not go, but if they are coming to you and if you want to start treatment, at least you would know which way to think about it. So the key takeaway points are recognizing the red flags. I mean, that's very important. Like if you see a teenager or even a younger child, I think what is more important, especially the youth population, because that's when these psychotic symptoms start happening for the first time. What are you looking for? Like looking for the whole picture. You're looking for what is full house, so looking at the red flags, recognizing that hallucinations in children can be related to anxiety, it can be related to depression, it can be related to stress, so to trauma. It is not automatically psychosis. So when we know that one of these other things are leading to these voices, then we should try and target the other things first. We should try and treat depression. I'm sure most of you will feel comfortable prescribing a low dose of SSRI to these kids just to kind of get rid of some of the anxiety, get rid of the depression, and that could actually help with the psychotic symptoms, because this is not true psychosis. This is a mood related psychosis. Early detection is extremely, extremely important. We are really in a place where if we start early, we can reduce the disability for these kids. Appropriate referrals, the destigmatization part, I cannot say enough about this fact that I can tell you from my personal experience, these kids, when they come from the pediatricians, they really trust their pediatricians. They don't trust me. When they come and see me as a psychiatrist, they don't want to see me. They don't want to be associated with anything related to psychiatry. But if their pediatricians told them that they're going to get help, they're going to get better, and the pediatricians advocated for it, then they feel comfortable with me. No kid has come to me and say, oh yeah, I love being here, I love being in your clinic. It's the pediatricians who start the process in their clinics, where they these kids that especially you're going to be okay, and I'm advocating for them and helping them understand the process, helping them understand what this means and where this is going to lead to, and how they're going to get better eventually. So that is the unique role of pediatricians, I think, in these kids, where educating them and also advocating for them at the same time. Collaboration with psychiatrists is really important. I'm so thankful and grateful for all the pediatricians who send the referrals to me and then also call me and talk to me and say, hey, what's going on with this patient, what's going on. So we collaborate because they see the pediatrician more than sometimes they see me. And if there is knowledge sharing, then we know that what's going on with the kid, and we kind of keep in touch like that. And continued longitudinal follow-up. As I said, a lot of these kids even refer they might go, they might not go. And what would happen is they might not go and they might deteriorate and they would come back after a year or 2 years, or they will be in a worse situation. They will be floridly psychotic. They would have developed schizophrenia by that time. So follow up with these kids and see where they're at. Have they followed up with the psychiatrist? Have they followed up with the referral? So that's kind of really also very important. That's pretty much it. So I'm just gonna stop sharing my screen. And yes, so
Thank you, Meha.
ready for any comment.
Thank you, Meha. That was a very elaborate description about early onset schizophrenia and also the role of pediatricians and how important it is for us to diagnose early and collaborate. And you very beautifully put forth the red flag signs. We had one question from Dr. Patanjali Shikhar, and he has said that before you start medication, you did tell us about some metabolic profile which you do as a follow-up when the child is on medication. But before you really say that it is psychosis, and do you do any tests before you say, like you said, Wilson's was one of the differential diagnosis, right? Wilson's disease. So do you do routinely LFT? Do you do any other metabolic parameters before you really term them as, what can I say, a non-organic psychosis?
Yeah, no, actually, that's a good point. So, yes, we do want to rule out medical causes, especially if there is any other corroborating history or anything else that points towards that direction. So you want to do like metabolic panel, and you want to do CBC, as I said. You want to do all the routine blood work, which is because it's easy. It's so easy to get these blood work done. Like you can send the kid and you can have the blood results within like 24 to 48 hours, I'm sure. So it's easy to just rule out anything medically or neurologically if possible. I wouldn't go necessarily to like really specialized testing, like NMDA antibodies or something that I wouldn't start with that. But the routine blood work definitely should be done before sending to a psychiatrist or just like ruling out any medical causes.
Okay, thank you, Meha. And can you tell us the association? Is there any association between ADHD and schizophrenia?
So there is no association like per se. It's not like ADHD can cause schizophrenia or schizophrenia can cause ADHD. It's not that. The thing is that the kids with ADHD, they're poor, sometimes poor historians. They are all over the place. They're not able to think properly. They're not able to like organize their thoughts. So if they do develop psychotic symptoms, it is hard to get history from them because they would not remember. Their memory is kind of weak. They're very forgetful. So then you have to rely on the parents' history and all of that. But ADHD does not cause psychosis, and psychosis does not cause ADHD. That is for sure.
Right, right. So they may present with poor attention initially, like you said, somebody who is presenting with psychosis, that may be one of the early indicators that there may be poor attention and loss of focus as far as academics goes, but not necessarily that this is ADHD.
No, that is not necessarily so. So psychosis can, one of the symptoms, as you said rightfully, that it could be lack of attention, but it would not be just lack of attention. There would be more. So to call a kid psychotic, you would see a lot more. It would not be just poor attention and that's it. There would be more. There would be lack of ability to take care of themselves. That there will be social isolation. There will be withdrawal. There would be some hallucinations, or there would be some mood related symptoms. This kid would not be functioning normally like other kids. And it's not explained by just attention or ADHD. There is something, you would see that there is something going on in the background which cannot be explained by ADHD at all.
Okay. Now, is this treatment of schizophrenia lifelong? Do you stop treatment in between? And how do you decide to stop treatment? And what's the prognosis?
So it depends. It depends on what is the underlying cause for the psychotic symptoms or schizophrenia. If it is, for example, if it is due to a substance use, so substance use psychosis, then if you stop using the substance, then yes, you would be in a period where you would have no symptoms. You can stop the treatment after at least, I give at least 6 months of being symptom free before stopping any treatment. If it is due to depression or anxiety that these kids are having psychotic disorder, then if the depression or anxiety is treated, then you can stop and the psychosis resolves after treating depression, then you can stop the treatment for psychosis. It depends the cause of the psychosis. If it's truly schizophrenia, if it's like, nothing else explains it, and this is schizophrenia, this kid is schizophrenia, there's family history of schizophrenia, and this kid is definitely in this chronic impairment state of schizophrenia, that is not curable but treatable. Those are the individuals who as adults remain on antipsychotics for lifelong. But again, as I said, that is very low percentage. Most of the other kids, there is some underlying cause, and you treat the underlying cause, and then you can stop the treatment after like a certain level of stability.
Okay, thank you, Meha. Do any of the other participants have any question? You can unmute yourself and ask the question from Meha. Anybody else? You have any question?
Should I check the chat? Maybe they've put something.
Yeah, I did check. I was checking
okay.
the chat. Yeah. I asked you a couple of questions from the chat itself.
Oh, I think Jijo should said something, which I think maybe you should talk about. It's a good message.
That is just answering from the pediatrician's point of view regarding the metabolic
Yes.
workup, rarer things which we think about. There's one more query was regarding lurasidone versus risperidone when it comes to a higher prolactin level.
Yeah, what's the query? Sorry, what's the question?
So Dr. Shikhar has mentioned that for him, when he switched from risperidone to lurasidone, it stabilized the prolactin levels in children when they were on a long-term therapy.
Yeah, it will. Yeah, switching from risperidone to any of the other antipsychotic medications, to aripiprazole, to lurasidone, or to quetiapine, it would stabilize the prolactin levels. That risperidone is the worst culprit for prolactin.
Okay, Meha, one last question. Is schizophrenia a neurodevelopmental disorder or a neurodegenerative disorder?
So that's a controversial question, and it's a very controversial topic, actually. So the short answer is that we don't know. We really don't know the exact mechanism of schizophrenia. Or, I mean, there's so many hypotheses. There's a dopaminergic hypothesis. There's a glutamate hypothesis. There's so much. There is, again, the two-hit hypothesis that I was explaining, that there is one hit and then there is another hit. So we don't know exactly what is going on. There is no genetic test which can predict if a person is going to develop schizophrenia, or what would be the age of onset of schizophrenia. There's absolutely no genetic test that can predict that. There are certain chromosomal analysis testing which can say, some syndromes like 22q11 deletion syndrome, some of those syndromes that they might have a higher probability of schizophrenia, but they still cannot say that this is this by having this particular genetic makeup, you're going to definitely 100% have schizophrenia. So we really don't know if it's neurodevelopmental or it's neurodegenerative. There is so much research done on schizophrenia, but there's so much still left to understand, that we are just trying to make sense of what we know. And what we do know is the fact that if there is a genetic predisposition, and if there is another stressor, and if we combine the two, the perfect storm happens and a kid develops a schizophrenia. And then lifelong, again, we don't know if it's neurodegenerative, especially because some kids do come back to baseline, especially if it's like substance use or something else, but then some is chronically impaired. So this is a gray zone which we really don't know the exact answers to.
Yeah, and I think taking a leaf from what you said, marijuana, which is so very common, especially with the family history, which if we know, we have to warn, I think, the adolescent that,
So
yes.
that is a very interesting thing, and I want to say a couple of things about that. So marijuana is legal in most states in the United States right now, and I have children, adolescents smoking weed all the time, smoking marijuana. They're doing joints after joints, and the thing with marijuana is that the tetrahydrocannabinol, which is the active ingredient, we know for sure, we have research that it does alter the brain synapses. It does work on the cannabinoid receptors in the brain, and it can cause increased dopamine. It can cause psychosis, and we don't know how much is enough. We don't know 1 joint per week is okay. We don't know 2 joints a week is okay. They come and ask me all the time, how much can I smoke? I have to smoke. I will smoke. How much can I smoke? Can I smoke 1? Can I smoke 2? No, I don't know the answer to that, because for some, again, it's your personal genetic profile, it's your personal genetic predisposition. For some, one would do it, they would go into psychosis, they would have hallucinations, they would have full-blown psychotic episode. For some, they can smoke joints after joints, they would not get psychotic. But we don't know who is going to react how. What we do know is that marijuana really affects it does affect the brain chemistry, and it does affect to a point where, especially the developing brain, because the kids' brain are still developing, and that on the developing brain, there is research to prove that marijuana affects adversely, and they become very prone to psychosis. And especially, as you said rightfully, if they have family history and if they have some genetic predisposition, marijuana just can be the second hit, and that's when they would just go ahead and develop psychosis. And the psychosis can be transient. There's something called blips, like brief limited intermittent psychosis syndrome, which is associated with marijuana. It could be blips, but it could also be a chronic schizophrenia that they might develop right after smoking marijuana.
Thank you so much, Meha. Thank you very much. That's a very, very informative webinar, and we can't thank you enough. We hope to see you again in India very soon, and we hope to continue these learning sessions with you. Once again, thank you, Jijo, and thank you, IAP Kerala, for arranging this very informative webinar. And I think the recording will be available, and we'll be sharing the link with all other friends who could not come here because of Deepavali celebrations, and wishing everybody a very happy Deepavali. Over to you,
Thank you, and
Jijo.
it was a pleasure. It was a pleasure for me. Thank you so much for having
Thank
me
you.
and having this great discussion. Thanks a lot.
Thank you, ma'am. Thank you, Meha, for that excellent session. It was quite eye-opening from a pediatrician's point of view, because these are not things which we are regularly used to, which we tend to pass on to the physician or pass on to the psychiatrist, things which we're not comfortable about. But like you rightly said, there's so much more we can learn, especially when we collaborate. And if, like you rightly said, this child might do better if the child is being referred by a pediatrician with whom he has had a much more longer relationship. So likelihood of the child continuing treatment is going to be much more higher rather than him going directly. So the dropout might be much more higher if in that scenario. So thank you for that valid point. And like she rightly said, if you are in a setup where you can't start that many times, you should be able to start off with at least a few of your SSRIs to see how the child is doing. Provide, if you can, definitely talk to the psychiatrist, refer the child early, rule out the common things which we think about. So these are all the take-home messages. We would love to have you back again discussing more topics, even if you are abroad. So at least for adolescent, we keep a slot open for us so that we can have another webinar coming up every year. Hoping to
Absolutely.
Sure.
Anything for you. Thank you.
Thank you so much. Thank you so much.
It's a pleasure. It is really a pleasure for me. And again, this gives me an opportunity. I really miss home and I miss India. And, this gives me an opportunity to collaborate. And this is really, truly a pleasure and an honor for me.
Thank you.
Thank you so much. Thank you,
Bye-bye.
ma'am. Thank you, ma'am. Thank you for giving us time in your busy schedule, Preeti ma'am.
Yes, thank you for the slot.
Yeah.
Thank you.
Yeah. Pleasure.
You're
Bye.
at conference today also.
Happy
Thank you so
Diwali.
much.
Happy
Happy Diwali.
Yes.
Happy Diwali.
Yes.
Good night, ma'am.
Good night.